Can I have your attention, please, all those who are especially standing on the back side? You may please occupy your seats. Now, this is the lecture which is preponed. This was scheduled on 30th of December, which is now preponed because there is some gap in between. And the topic is NHM programs in India. Now, some of the students who are sitting over here are looking quite senior, and maybe to some extent when they are working in the field, they are familiar with NRHM or NHM as such. And those who are very new, my job is to make them familiar with this particular topic. I am very happy that CPS has invited me for giving this particular lecture for the simple thing that I have seen the gaps between the FCPS or MD as clinicians, and when it comes to apply that particular skills or knowledge to the public health. So taking that into account, this becomes very important. And please don't write anything. If you want, I can keep this on the hard disk. You can copy it subsequently. But try to get familiar with whatever things are being said. The topic is too huge. If you ask me how long you will take this particular topic, or when it comes to teach the students, UG, PG, whatever it is, it altogether means 7-8 lectures, which I am supposed to consolidate in 45 minutes. Okay, so maybe that we will have to rush through. You are already to some extent familiar with, but try to understand. As a clinician, I am very particular about these things because there are lot many gaps when it comes to apply the knowledge of a clinician, especially gynecologist, which we have witnessed in the field, when it comes to reach to the public health. And I am from the public health side, whereas you are from the clinician side. Okay. So when I say NRHM, okay, today it is NHM. NRHM is the term which came into existence in the year 2005, whereas since 2013 we are talking about NHM. NRHM, the word includes rural, National Rural Health Mission, and this is the symbol of this NRHM, which highlights mainly these three things, that is, mainly four things, that is the newer initiative. If you see this particular emblem or if you see this particular logo, you will find there is a sun which says you have to identify certain newer initiatives. Rural poor person, address to rural poor person. Now we don't say only rural people, it equally applies to even urban poor also. Hence we say now it is urban health mission and not limited only to rural people. It has to be the holistic approach, and there is a very major big component of monitoring and supervision to express your accountability to the services which you are rendering to your patients. Okay, so this is what this logo conveys to us as far as NRHM is concerned. Now what are our areas of concern? Not many things are already achieved. There are many things which we have already achieved, but it is equally true that there are many gaps also. Now we have, this is under 5 mortality rate, what is the gender gap and what is the rural urban gap, what we always call it as not equitable distribution, or this is in true sense the equity related concern. Now if you see what happens to India, Bihar, Assam, Haryana and various states, and on another side rural urban gap, that means the gap exists. And if you compare this the situations with NFHS 4 data, National Family Health Survey data 4, which was completed in the year 2006, even today you will find that the institutional deliveries in public health facilities to the tune of almost 46% all over the country, JSY benefits to the mothers only 21%, full immunization coverage 63.9%, breastfed within 1 hour of birth only 42%, anemia 15 to 49%, in the age group around 45%. Children between 6 to 59 months who are anemic is around 55%. This was the situation in the year 2016. Okay. Now again, if you see what is the difference between NFHS 3 and NFHS 4. NFHS 3 got over in 2005, NFHS 4 got over in 2016. That means there was a gap of almost 10 to 11 years. And how much is the achievement in a period of 10 to 11 years? Again, you will find that there are lot many gaps, and our progress has been all the time very slow as compared to what the progress we had anticipated to be achieved in next 10 years. Okay, so these are our areas of concern. So in spite of making so many differences, still the gap remains, and we need to do something more aggressively to address all these gaps, especially ANC coverage, teenage pregnancies, early initiation of breastfeeding, complementary feeding, underweight, children with diarrhea who receive ORS, full immunization coverage, pregnant women who are anemic, IFA coverage, and contraceptive or mean couple protection rate. So all these you will find the gaps, and you will also witness a very marginal increase in a period of 10 years. That means you need to do something very aggressively to address all these issues. So then what is National Health Mission? Now National Health Mission, this word was coined in May 2013 to encompass practically all those things who are the core activities of public health sector. Okay, this is like an umbrella program. Everything has to be covered under one umbrella, which is National Health Mission. So today, whatever you talk about related to MCH, RCH, etc., it goes under National Health Mission. So the core values. Now all these core values, etc., is something which you know, even if you don't read, you will be able to. We need to do something good for everybody, and it is not that you are doing it, it is equally important, as this particular program says, that it has to be perceived in that way. It is not enough that I am doing it, it is equally important what National Health Mission says, that it has to be perceived in that way. Mera Aspatal approach. Okay, so safeguard the health of the poor, vulnerable and disadvantaged will be a common thing. Strengthen public health system as a basis for universal access. Build environment of trust between people and providers of health services. Empower community to become active participants in the process at attainment of highest possible level of health. Institutionalize transparency and accountability in all processes and mechanisms, and improve the efficiency to optimize the use of available resources. So if you read in total, that means something good needs to be done on the part of the health provider, which is going to be perceived by the beneficiary. So it is not enough that you are saying that you are doing it. If it is not perceived that in that fashion, then it is not enough. Now National Health Mission goals. There are certain goals which are prescribed. Now these goals you must have read it on different fronts. SDG goals are there, Millennium Development Goals are there, National Health Policy goals are there, National Health Missions goals are there. More or less they are close to each other. This is reduced maternal mortality ratio to 1 per 1,000 live births or 100 per 1 lakh live births. Reduce infant mortality rate to 25, reduced total fertility rate to 2.1, prevention and reduction of anemia in women, prevent and reduce mortality, morbidity from communicable, non-communicable. So when I say National Health Mission, it is going even beyond your MCH domain. Okay. Now it is not limited only to RCH or MCH domain. It is even going beyond control of certain communicable, non-communicable diseases, reduced household out-of-pocket expenditure on total healthcare expenditure, reduce annual incidence and mortality from tuberculosis by half, reduce prevalence of leprosy to less than 1 case per 10,000 population and incidence of 0 in all the districts, annual malaria incidence less than 1, less than 1% microfilaria prevalence in all districts, and Kala Azar eliminations in 2015, which is yet not so, and less than 1 case per 1,000 population in all the blocks. Now Kala Azar is limited only to few areas all over the country, some part of West Bengal, Bihar, and some part of Uttar Pradesh. Okay. So these are the goals which are set. Only important thing what you have to remember is beyond maternal mortality and infant mortality, it is now extending to some communicable and non-communicable diseases also. So when I say National Health Mission, what does it mean? So National Health Mission today encompasses National Rural Health Mission. Now this is something which was introduced in the year 2005, mainly to address the issues of rural population. Then National Urban Health Mission, which now addresses the issues of even urban poor people. Communicable Diseases Program, NCD program, and infrastructure maintenance at all the levels, right from subcenter to the district hospital. Now when we say NRHM, the priority areas of course is the RH, RCH, reproductive and child health, which is RMNCHA plus N, which is reproductive, maternal, neonatal, child health, adolescents plus nutrition. So everything under one umbrella. And of course, the next major program is immunization. Then health system strengthening. What health system strengthening means will come subsequently. As far as communicable diseases are concerned, the priority goes to RNTCP, National Vector-Borne Diseases, National Leprosy Elimination and Integrated Disease Surveillance Project. Non-communicable diseases under NHM, the priority areas are National Program for Control of Cancer, Diabetes, Cardiovascular Diseases and Stroke, NPCDCS, National Program for Control of Blindness, National Mental Health Program, National Tobacco Control Program, and National Program for Health Care of Elderly. They are the priority areas when we talk about national health missions. So in general, National Health Mission envisages the achievement of universal access. Universal means to everybody, everywhere, every time. So all three parameters are included in the word universal. To equitable. Equitable is according to the need. Those who need more should be provided with more. Those who need less should be provided less. On that principle, if rural people they need more care, they should be provided with more care. If females they require more attention, they should be provided with more attention. That is what it means. It should be affordable. Nobody is going to be pushed into a below poverty line only on the ground that they have to spend on the health. So it has to be affordable. The key word when we talk about NHM and universal health coverage is the quality healthcare services that are accountable. We are accountable to what we are doing. We are accountable, and accountable here is equal to answerability. So you are going to be answerable to what you are doing and responsive to the people's need. So your services ultimately should address what people want. It should not go in one way that I am supposed to do this, whoever wants we will take it. I am least bothered about what people want. I have been told to conduct this, I have been told to do this, so I am doing it without bothering what is really required. That should not be the scenario. So when we say NHM, all these are the keywords, that is universal, equitable, affordable, quality, accountable, and responsiveness. So they are the words. Anything when you talk in terms of these words, anything what you describe by incorporating these words goes into a national health missions. Okay. So national rural, to begin with, National Rural Health Mission. Now this National Rural Health Mission was announced on 12th of April 2005, and initially it was tasked with addressing the health needs of 18 states with weak public health indicators. Now these 18 states were mainly from Northeast side and North India side, that is Rajasthan, UP, Uttarakhand, West Bengal, and 7 states of Northeast. Okay. So the major objectives then, because initially this program was meant for 2005 to 2012, which is now extended in the form of NHM. Initially, of course, every time it is reduced infant mortality and maternal mortality, provide access to public health services, which includes women's health, child health, water sanitation, hygiene, immunization, and nutrition. So all basic services in public health. Prevent, control, communicable, non-communicable. Population stabilization has all the time been the first priority in whatever public sector health related activities are concerned. Gender and demographic balance. Revitalize the local health traditions, including mainstreaming of Ayush and promotion of healthy lifestyles. So communicable, non-communicable, RCH, nutrition, everything now gets incorporated under one umbrella, gets covered under one umbrella, that is NRHM. So what were the NRHM strategies? So we said that, okay, we will do all these things. But then by how? What is that mechanism? How these things are going to be really become visible? How they are going to come into existence in true sense? So provision of ASHA. I hope ASHA worker is a familiar face or familiar person for those who are working in the rural areas. Village health plan prepared through the panchayat involvement. Today the panchayat Raj system is involved totally in planning, making village plans. So the plans are made at the village level, are sent to panchayat samiti, to district, then to the states, and the state to the country. This is how the flow of information will go. Integration of vertical health programs and traditional medicine, vertical health programs especially for leprosy, TB, malaria, etc. Integration of plans at different levels altogether. New health financing mechanisms. What new health financing will come subsequently. Strengthening subcenter through an untied funds. Strengthening existing PSCs and CSCs. If you have witnessed the working conditions at the PSC, CSC, you will believe in this one. Strengthening capacities for data collection, assessment and review for evidence-based planning, monitoring and supervision, and developing capacities for preventive health care at all levels by promoting healthy lifestyles, reduction of tobacco consumption and alcohol. So in toto, you have to look for the holistic health when it comes to provide the services through NRHM, and the supplementary strategies are regulation of private sector, mainstreaming of Ayush, reorientation of medical education and social health insurance to translate all these strategies in true reality. So then what is this ASHA worker? I am not expanding this particular thing ASHA worker, but all of you must know that there is a worker, a voluntary worker who exists, who takes care of majority of the work at the grassroots level related to RCH or RMNCH plus A plus nutrition. So this ASHA worker is supposed to be basically a resident of the village, a woman who may be married, widowed, divorced, whatever it is, in the age group of 25 to 45 years with formal education up to 8th standard, having communication skills and leadership qualities. And there is a proportion, unit 1 ASHA for 1000 population. It is chosen by the panchayat to act as an interface between community and the public health system. She will represent the community side. She is like a voice of the community when it comes to reaching to the panchayat system. She is the bridge between auxiliary nurse, midwife and the villagers. She is a voluntary worker receiving performance-based compensation. There is no fixed salary. Whatever activities they are performing, whatever they become eligible to by virtue of whatever activities they perform, it applies to that. And then to create awareness among the community regarding nutrition, basic sanitation, hygienic practices, healthy living, etc. Her work is also to counsel the women on birth preparedness, important self-delivery, breastfeeding, complementary feeding, and immunization, contraception, STDs. So all routine public health services she is going to address when it comes to delivering the services at the grassroots level, that is village level. Encourage the community to get involved in health related services. Escort, accompany pregnant women, children requiring treatment and admissions to the next level or the nearest primary health center or even nearest CSC for that matter. Primary medical care for minor ailments such as diarrhea and fever when it comes to providing home-based care, and provider, she can also act as a provider of DOTS for treatment of tuberculosis. Okay, so these are the major elements or the major activities what ASHA worker is expected to do at the grassroots level. And these are various reference manuals for the functioning of ASHA, and as on today we have almost 8.9 lakhs of ASHAs who are now working in the rural areas, along with around 63,000 of USHAs. They are the urban social health activities who are now placed in urban areas. So what is expected when you say NRHM components? These components, PSCs and subcenters. So as a part of NRHM, what is expected at PHCs or at subcenters? It is adequate regular supply of essential. I hope you know that there is a list of essential drugs even for each primary health center. Now usually this list is displayed at the primary health center level, and whatever it is a list of about 21, 22 drugs, and all those drugs have to be made available all the time to everybody at whatever time they report for services. So any day, if you go through the records and if you find that yes, there are certain number of dates over here when these drugs were not, certain drugs were not made available, then you say that yes, you have not observed the principle of provision of essential drugs. So to that extent, the commitment or accountability rests with us. Then observance of standard treatment guidelines and protocols. Now these standard treatment guidelines and protocols have come into existence and they have to be put into operation. We have witnessed in the medical audit at the rural hospital level that these standard protocols, everything, in spite of making them available, they are not being followed, and the range of patients which are managed at that level, as well as the treatment component or the treatment guidelines which are observed are very different. When we say that you are not creating the cases of typhoid fever, they say how many cases of typhoid fever you need. We can just add those many number of cases without even bothering any time ever they have addressed these cases of typhoid fever. So to that extent, and then intensification of ongoing communicable diseases control programs. When we say intensification, always remember that yes, you will do more work, but at the same time you are equally concerned for that particular work. When it comes to tuberculosis, it's one of the priority program under NHM, and if you ask the medical officer how many cases of tuberculosis you have, and if they are not in a position to answer that question very instantly, then we say that yes, there is no commitment, there is no concern. Okay, otherwise what your medical officer will say, he'll say that okay, just wait, I will ask my pharmacist and I will let you know. Now this answer itself reveals that there is a problem or there is a concern. Then upgradation of 100% PSCs for 24-hour referral services. We want to convert them into what is known as 24/7 PSCs. Okay. As far as subcenter is concerned, yes, there is a provision of untied fund. Untied means it is not tied to anything. It is meant to be used as and when for the purpose, whatever sounds true or whatever sounds appropriate at that point of time. So there is no earmark, yes, so much of money for this purpose. It is not that. That's the reason why it is known as untied. Supply of essential drugs even at subcenter level. Additional ANMs wherever required. If the delivery load is very high, then usually they appoint one more. Usually at subcenter, you have one ANM plus one MPW. If required, one more ANM can be appointed at subcenter level under NHM. Sanction of new subcenters as per 2001 population. See, today we have one subcenter for 5,000. So if you take into account the total population of the country and if you divide the total population by 5,000, whatever number comes, those many number of subcenters have to be there, which is not so in true sense. There is a deficiency of 15-16%, so that number needs to be corrected. And upgrading existing subcenters, including buildings for subcenters functioning in rented premises, will be considered. So there are many subcenters today which are in the rental place, and they have to be replaced with a standard architect of whatever is earmarked for the building of sub-centers. Now when it comes to CSCs or our rural hospitals in the state of Maharashtra, then operationalizing CSCs as 24 hours first referral units, including posting of anesthetics. So whatever is meant, all the operative delivery services 24 hours, LSCS or gynecologist services 24 hours, operative services 24 hours, they have to be provided, and there has to be some provision either on the contractual basis or on the higher basis of anesthetist for that purpose. Then there are specific Indian public health standards, IPHs, which are prescribed for the functioning of rural hospitals, which have to be put into operation. Rogi Kalyan Samiti to voice or to be responsive to the demands of the peoples, standards of services and costs in the hospital care, citizens charters to be displayed very properly, and new CSCs 30 to 50 beds as per the census of 2001. So usually we have one CSC or rural hospital in the proportion of 1 for about 1 lakh of population. So again, if you divide the total population by 1 lakh, whatever number comes out, we do not have the number of CSCs by that number. The deficiency is to the tune of 40 to 45%. Okay, so that many new CSCs have to come into existence. When it comes to developing district health plans, what is expected under NRHM is that you need village level plans. Okay, so village health and nutrition committee, which is now in place in all the villages where there is a Gram Panchayat, they are the one who are supposed to prepare their own health plan. These health plans would be from the core unit of action proposed areas like water supply, sanitation, hygiene and nutrition. Then district core unit for planning. So ultimately it is a district which is a core unit of planning. So district will plan based on whatever plans they receive from the villages from their districts, from the PSCs from that particular districts, from talukas from that districts, etc. Then centrally sponsored schemes need to be modified in consultation with the states to customize to their own needs. And today we have what is known as district health mission as well as state health mission. Along with national health mission, you have a state health mission located in Arogya Bhavan, and in each district today it is an umbrella program. Previously we used to have a separate civil societies like district AIDS control program, district tuberculosis control program, district blindness control program. Now all these things are put under one umbrella, that is district health mission. So when it comes to disease control programs, these are the priority areas, that is malaria, TB, Kala-Azar, blindness, iodine deficiency disorders and disease surveillance project. New initiatives for control of non-communicable diseases, that is especially various screening programs for hypertension, diabetes and various types of cancers. Disease surveillance at the village level, we do expect to mount a community-based disease surveillance. Now what disease surveillance today we have? We are collecting the information from the hospital. So our disease surveillance is totally hospital-based. We need to make it community-based so that in true sense you will get to know what is the true burden of that particular disease in the area. See, if you ask me for the city of Mumbai, I do not know how many cases of malaria are there in the city of Mumbai. Whatever figures I am going to dictate, they are the figures which are made available by different hospitals. So if my hospital reporting is not going to be completed, I will not know the exact number of cases of malaria, because there are many who are going to dispensary, private sector, who are leaving Mumbai, going outside Mumbai. We do not know anything about that. So all these issues in disease surveillance need to be addressed. Then supply of generic drugs in Ayush as well as in allopathy, and mobile medical units at district level. Today all the districts are provided with mobile medical units. You need to monitor the functioning of these mobile medical units. Public-private partnership for public health goals. Now remember that we want to incorporate even the services of private sector to accomplish certain public health goals, because it is a true fact that almost 50-60% of the population still avails the services from the private sector. So that needs to be addressed. So district health mission must have a representatives of the private sector, guidelines for public-private partnerships, and public sector to play a lead role in defining the framework and sustaining the partnership and management plan for public-private partnership initiatives. So all these things, they sound very big things, and when it comes to what does it really mean to us, you have to come out with a definite plan. Yes, this is what private sector will do. This is how the public sector is going to help. Identify one key area, make a proposal, submit it to district health mission, and appropriately MOU can be signed, and if required even funds can be released. So all those mechanisms, identify the areas where yes, this partnership becomes very essential, devise your own strategy, get it approved by the district health mission, and make it available to the people. Okay. So as far as disease control is concerned, new health in a financing mechanisms. When we talk about new health financing mechanisms, what is it? Of course, everybody is aware about the user charges. Now today we have user charges practically for everything. Then standardization of services. You need to standardize services. When you mean that yes, contraceptive, family planning services, what does it mean? That needs to be specified very correctly. Then district health accounting system, you need to take into account how best you are utilizing your monetary resources, adequate technical, managerial and accounting support, community-based health insurance schemes, and Government of India subsidies to cover a part of the premiums for the poor and monitor the schemes. So this is the health insurance schemes basically. Then the reorienting health and medical education. What really needs to be done on this particular front is medical and paramedical education facilities to be created at the state based on the need assessment. Today we don't get dialysis assistant, a dialysis technician. We are not getting the perfusion technicians. We are not getting CVTS technicians. So all these services, wherever there is a need, that needs to be looked into. Then suggestion for Commission on Excellence in Healthcare is under consideration. National Institute for Public Health Management. Yes, we have Public Health Foundation of India, but there is no institute on this name. And you definitely need a task group to improve the guidelines and details even in public sector. Okay. Now monitoring evaluation, what NRHM envisages when we say monitoring and evaluation, what do they envisage? Health MIS to be developed up to CSC level and web-enabled citizen scrutiny. Now today, this HMIS, Health Management Information System, is in place. Now it collects the data from all rural hospital, primary health centers, district hospitals, etc., etc. Now this data you can avail from the website, and this is a true monitoring of to what extent you are meeting your goal from time to time from different areas. Sub-centers to report on performance of panchayats, hospitals, Rogi Kalyan Samiti, district mission to Jilla Parishad. So who will report to whom, at what frequency, by what date, and on what parameters is fully decided, and it is a well-structured MIS system which is in existence today. The important thing is that many of the clinicians, they are not even aware that such and such system is existing, and they have never bothered even to go through those reports to assess to what extent the information is reliable and appropriate, and that is what is really required. Then district health mission to monitor the compliance of citizen charters. You are answerable, you are accountable, you are committed to render certain services, and to what extent you are fulfilling your norms, that needs to be monitored. Annual district reports on people's health, state and national reports on people's health to be tabled in assemblies and parliament. External evaluation, social audit through professional bodies and NGOs. You need to do even social audit. It is not enough that only medical audit is performed. Social audit will take into account what is the expectation of the people and to what extent you are fulfilling those expectations. There are going to be many people who have never entered for their for availing the treatment into public sector, but still they do express their expectations from the public sectors. Even they also need to be addressed. And mid-course reviews and appropriate correction. So from time to time, you have to place the things in action who will take care of this mid-term course evaluation or mid-term reviews at different levels. So these are the health goals and targets, that is sustainable development goals. Now the only purpose of showing this particular slide is that yes, sustainable development goals are existing, they are also well defined, and they are also in line with NHM goals, they are also in line with national health policy goals. So all these, whether you are talking about national health policy goals, whether you are talking about sustainable development goals, whether you are talking about NHM goals, they are complementary to each other. So always remember that maybe the timeline may be different to some extent, because when you say SDG, that means they have to be achieved by the year 2030. When you say NHM, they are to be achieved by the year 2025. So what is expected to happen at, and what is happening, or to what extent as far as maternal health services are concerned, we have achieved. Lakshya, I do not know whether you are aware about Lakshya guidelines. Lakshya guidelines have come into existence. The definite infrastructure, how the infrastructure for delivery services has to be there is well specified, well spelled out. Okay, and all those things are to be created. So 2035 facilities, including 179 medical colleges, they are in progress. Okay, I hope you are well versed with Lakshya guidelines. Janani Suraksha, so far 10.6 millions beneficiaries per year. Pradhan Mantri Surakshit Matrutva Abhiyan and comprehensive ANC care, so far 16 million checkups. These are the figures updated up to 2019 May. Strengthening FRUs and delivery points, so many. MCH wings, more than 600 MCH wings are already existing in various rural as well as district hospitals. Capacity building of human resource. Dakshata LSAS is like life-saving anesthetic skills, because they are the regular training programs which are going on. Universal screening for HIV, syphilis, comprehensive abortion care services, Janani Shishu Suraksha, and obstetrics, high dependency units as well as ICCUs. Okay. Now the purpose of showing all these things, remember that it sounds very theoretical, but when it comes to make it happen, you should be well concerned with all these things. A gynecologist who works at the rural hospital level, if he is questioned a very simple question that how many high risk pregnancies are there, they fail to answer these questions very properly. How many high-risk pregnancies you are managing at this point of time, they are not expressed. Whoever comes in front of me, whatever personal care, individual care he requires, I will provide, but I fail to refer, or I fail to look into all these issues. That should not be the scenario. So all these things are happening, and you all are the part to accomplish all these objectives. So these are the Lakshya objectives: to reduce maternal and newborn mortality, improve quality of care, and to enhance the satisfaction of beneficiaries. So I am providing is not the answer. The way it is perceived and the way the level of satisfaction is expressed by the beneficiaries is equally important. If all three things take place together, that means you are observing the Lakshya guidelines very properly. Then Janani Shishu Suraksha. I need not speak about Janani Shishu Suraksha Karyakram in detail, because you are already familiar. It takes into, it provides the services even to the pregnant women as well as to the children till they complete 1 year of age, okay, including whatever transport activities and services they require, totally free of cost. So almost 1.3 crores women are availing benefits of free entitlements every year under this particular scheme. And as far as individual benefits are concerned, you may see the coverage coverage percentages. This is very familiar. Every month on 9th, there is a program of ANC checkups at PSC level. This is Pradhan Mantri Surakshit Matrutva Abhiyan, okay, which is again a major thing. Over 16 million quality antenatal checkups conducted and over 9 lakh high risk pregnancies identified, 25% checkups in high prevalence districts. 13,200 facilities provided. Facilities provide these particular services, and over 5,500 volunteer doctors from private NGO sector are working for this particular scheme, that is Pradhan Mantri Surakshit. I hope you are familiar with this particular, because wherever this service is going on, gynecologists are invariably involved into it. Remember that the program today says that at least one ANC checkup has to be done by a medical officer for each and every pregnant women. We are finding it very difficult to meet this simple target. There are n number of women who have never seen a face of a doctor all throughout ANC period till they are delivered. That's the scenario, and this is something which you need to look into. Then nutrition, this is Poshan Abhiyan. This is another flagship program which is going on. This is for enriching the foods with micronutrients by fortification to address micronutrient deficiencies. So new fortification standards for rice, wheat, oil, milk and salts have been recently released by Ministry of Health and Family Welfare. So whatever are the common raw ingredients people consume, you need to identify the scope to fortify them with various essential micronutrients. Facility beds management of sick SAM children, severe acute malnutrition children by nutrition rehabilitation at nutrition rehabilitation centers, and weekly iron folic acid supplementation program, and this is a Poshan Abhiyan. So when you say Poshan Abhiyan, right from ANC services, there are total 10 elements which are included into it, okay, and you have to monitor this very regularly. Anemia Mukta Bharat, AMB, estimated 440 million beneficiaries are there, and when you say these are the 6 benefits which go under Anemia Mukta Bharat scheme, okay. So there are many IT initiatives which are introduced very recently as a part of NHM, like Laksh portal. All states, union territories requested to log in and upload all Laksh related data. Similarly, you have RCH portal, you have mother and child tracking system. There are many new apps which have come into existence to strengthen your monitoring and supervision system. So certain new initiatives which are yet to be introduced are the delayed cord clamping. Delayed cord clamping has shown improvement in oxygen saturation in newborn. ANC guidelines, that is at least one medical examination by a qualified doctor. Referral guidelines, when and how, where to refer the most critical during emergency situation, and protocol for referral under process. Today we do not know that medical officer just keep on referring the patient to the next level. What for, and the accountability set to that is not known. For example, there are certain very clear-cut guidelines that if you are working at a rural hospital level, what are the minimum skills you should have and what type of patients you should manage. If you are going to refer the patient which otherwise you are expected to manage at the rural hospital level, you need to specify the reasons for referral, which people are not even aware about it. Okay. Then focus on the respectful maternity care. Now this respectful maternity care is linked to observance of Laksh guidelines. Okay. So universal immunization, this is a immunization is again a very big and huge program. Okay. So annual target is 2.67 crores newborns. I am not giving you all these targets, but you know that this is another flagship program and very huge program, and today what we are doing is intensified mission Indradhanush program. So this is the roadmap of vaccine introduction of recent origin from 2011 onwards, 13, 14, 15, 16. You will see that in the universal immunization program itself, not many new vaccines are getting added. And this is the standard immunization schedule which we are observing today, which includes zero hepatitis B or hepatitis B birth dose, then rotavirus in certain areas, PCB and MR1, MR2 and TD vaccines. TD vaccines have yet not made available. TD is adult tetanus and diphtheria vaccine. So they are the one which are added into it. So to some extent, immunization schedule has changed in the sense that they have incorporated more number of vaccines into it. So two milestones is that the polio free and elimination of maternal and neonatal tetanus. So they are the two landmarks achievements on this front line. Today we have intensified mission Indradhanushya. Mission Indradhanushya was supposed to meet the targets by 2020 and the government then intensified it in the year 2017 to say that yes, whatever was to be achieved by 2020 will be now achieved by 2018-19. So these are the rotavirus PCV vaccine expansion plans. This is how they are added into, they are the new vaccines which are added into these programs. So same thing for MR campaign and injectable polio vaccine. So they are now included into immunization schedule. Japanese encephalitis and TD vaccine is going to get introduced very soon. Japanese encephalitis in certain high endemic districts. Then electronic vaccine intelligence network is rolled out. This is real-time stock management and real-time monitoring of cold chain temperature. I am not very familiar with this particular thing because it has not come into existence, but inventory management and cold chain management is now going to be by this particular software. Then why are the children dying? See, these are the various causes of deaths, especially amongst the children who are less than 5 years, and these are the various programs to address. We have the most common preterm births, complications, intrapartum events, meningitis, which are being addressed into neonatal care programs. Malnutrition, you are going to address it under nutrition program, that is Poshan Abhiyan. Pneumonia, diarrhea, management of childhood diarrhea and ARI diseases. Sepsis, meningitis, tetanus, strengthening immunization programs. Congenital anomalies, you have what is known as Rashtriya Bal Swasthya Karyakram, which mainly looks into congenital anomalies programs, and injuries which are looked into routinely. So Rashtriya Bal Swasthya, it is mainly 4 Ds. They will look into defects in birth, deficiency, diseases at childhood, and developmental delays. And this is the proportion. That means a huge number of children have to be addressed on each D as far as this is concerned. Then you have something known as Rashtriya Kishore Swasthya Karyakram. This is mainly to address the issues of adolescents age group, and they are the components like sexual and reproductive health, risk for NCDs, substance misuse, injuries, violence, mental health, and nutrition. These are the core areas under this particular program. Then these are the service packages at health and wellness clinic. Now the proposal is to convert practically all sub-centers into health and wellness clinics, and besides whatever is happening today, we want to add services being added in incremental manner, that is basic oral health, screening and basic management of mental health ailments, care of common ophthalmic ENT problems, elderly and palliative health care, emergency medical services including burns and trauma. So it is envisaged that in this health and wellness clinic, these new services are going to be added besides whatever is rendered through sub-center as on today. Okay. So these are the interventions under NHM. This much is already achieved. A huge proportion. Already many things are done, but still many more things are yet to be achieved. Okay. So HMIS is the web-based management information system launched by Ministry of Health and Family Welfare in 2008, which is in operation. There are n number of issues as far as HMIS is concerned, and most of the issues are from rural hospital, primary health center, because the appropriate data is not rendered to this particular portal. Okay. Objectives are to monitor the performance and quality of healthcare, evidence-based health planning, repository of information, effectiveness, efficiency, coverage of health programs to improve availability, access of healthcare, and developing and monitoring performance. Uses, of course, to PIP, to develop PIPs, that is program implementation planning. Evaluate the state's performance, grading of PSCs. Who is performing well, who is performing worse, that is something which is possible based on this particular data today. Then today you also have NUHM. Now when I say urban health mission, this is the national urban health mission was approved on 1st May 2013 as a part of submission of national health mission. It aims to establish and strengthen primary healthcare delivery in urban areas with focus on slums and vulnerable population. Now this is a very big problem. Let me tell you that if you are going to visualize the situation in Mumbai or Pune, the things are different. But when it comes down to a very small villages where there is Nagar Palika, Nagar Parishad, etc., they don't have any infrastructure to look after their population. Health rests with local self-government, okay, but they are not empowered to that extent. They get excluded because they are not rural areas. They also get excluded because their local self-government is not empowered to take care of this health. And these are the areas which need attention. So this National Urban Health Mission is something which applies provisions under National Urban Health Missions. They apply to areas where the population is more than 50,000. Where it is less than 50,000, it is still looked after under NRHM. Okay. So these are the core areas. More or less they are same as that of what you have already seen for National Rural Health Mission. So we need urban CSC, something equivalent to rural hospital in urban areas. Urban PSC, that means some infrastructure equivalent to PSC what you see in rural areas. Outreach sessions and Mahila Arogya Samitis to create the demand for these various services. So 1067 cities today are covered under this particular flagship program. Lot many guidelines are available to make it operational. Then there are certain health indicators. If you see the table behind, you will find that you will find the proportion of government expenditure as percentage which goes for health. Okay, and where it is less, invariably your MMR, NMR, under 5 mortality and life expectancy, all these rates are going to be very poor. Okay, so you need to put in more money as far as health sector is concerned. The guidelines are given. We want to raise that up to 2.5% of GDP. We want to raise it from 1.3 to 2.5% of GDP into health. 1% of GDP is equal to 2.5 lakh crores as far as in terms of money it is concerned. So you can identify what this particular slide shows is that the huge amount, that out of pocket expenditure constitutes the huge amount when it comes to health expenditure. And today the government aims to reduce this particular proportion of OOPE. So you have what is for, in order to address this, what is available in NHM is Ayushman Bharat, which aims to provide holistic care, prevention, health promotion, primary, secondary, tertiary care in an integrated fashion. So Ayushman Bharat is a very important program as far as this is concerned. Now takes steps to be taken to ensure availability of human resource in health. Today we are finding this very difficult. There is no doctor, MBBS doctor at primary health center, only for the simple reason that each MBBS person today wants to pursue the career in PG, and there are no doctors at PSC level. So these are the various options the government has identified to fill all these particular posts. I hope you will agree with all these things? Yes? These are the plans. So please remember. This is National Viral Hepatitis Control Program, which is a new program which has come into existence under NHM. So these are the key interventions. Then you have National Program for Control of Cancer, Diabetes, CBTS. All this is not important. National Dialysis Program, Pradhan Mantri National Dialysis Program is also in existence. Palliative care is a new element which is coming up. So the proportion of people in senior citizens categories is increasing. You have to take care of them. Model health districts, IPHS revision. This is what? Life-saving dot, iodine bindi. And what is your role in NRHM? So after all this entire Ramayan, what are you supposed to gain out of the whole thing? Because this is really a very huge topic to be covered in 45 minutes. So what is inspected is respected. That means you should be concerned, then only you will make it possible. If you are not concerned, then nothing is going to happen. You must look beyond your individual patient. What we expect when we talk about NHM, optimum utilization of human resources, yourself as well as those who are working with you. Express the concern for unreached. When you work in public sector, it is equally important that those who are reaching to you, you are definitely going to look after, but you are also expected to be equally concerned with those who are not directly reaching to you. Monitor supervision, trainings, advocacy for quality as well as information, education, communication, and please respect the records and reports. Because our clinicians, they don't respect the records and reports. Okay, so this is how. So my job was to make you familiar with what is existing under the umbrella NHM. I will not claim that I have taught you everything about NHM, which is beyond the scope of 45 minutes. So you are familiar, you have heard something, and this is what is expected out of it. Okay, thank you very much.